Well, thank you, Senator. That was a very kind introduction. I appreciate that. It's always a great privilege to be part of CSG events. I'm really, really happy to be here, and it's such an honor to be part of this panel. I'll try to get my part out of the way so you can hear the other speakers who I'm personally interested in hearing what they have to say. As Senator Denton said, I did come prepared with maybe more material than we have time to do. I've literally taught 3-hour graduate seminars on health policy with less material that we're going to try to cover here in the next 25 or 30 minutes. So I'm going to get through this very, very quickly if we can. And if I can find how to advance the slides. How are we doing here? Okay. If I need to ask you to go to the next slide, I can do that. See if we can do that. What we're going to try to do today is to touch on, really focus on healthcare costs. What I'm going to try to do is to just do a very brief laying out of what the issue is and how high healthcare costs are and how fast they're growing, and show how we're not getting all the value out of the tax dollars that you're responsible for administering. We're going to talk a little bit about how important it is to slow the growth in healthcare spending, and yet how hard it is, especially at the state level and with Medicaid. And then look a little bit about what strategies states have tried, what they've been doing across the country, especially in their Medicaid programs, and what are some of the more promising strategies that states will be have the opportunity to do in the immediate future. Just very briefly to kind of look at how big the issue is in this country. In this country, I'm sure you've seen this slide or one like it many times, but in this country, the healthcare costs are higher than they are any place else in the world. The per capita healthcare costs in America right now, a little over $7,500. That is roughly twice the average of other industrialized countries that have universal health coverage for their populations, more than 50% higher than the next closest country. When you look at this as a share of GDP, which is kind of our ability to afford it from within our resources, again, we see that the United States has, by far and away, the largest share of its economy dedicated to health care, and it's been growing faster than in other countries as well. Now, when you boil this down now to what it looks like in dollars, in terms of what does it cost for a family health insurance premium, just looking back over the past decade, what we see is that the average cost of a health insurance policy is more than doubled, from roughly $6,000 to well over $13,000 over the last 10 years alone. And even though you can't see the numbers too well in the blue part of this graph, this is the amount that's borne by employees. And this has grown by about 150%, from roughly $1,600 to about $4,000 over the last decade. It's no wonder this issue has become so significant, not just for individuals, employees, but also for the businesses that pay the largest share of the bill for employer-sponsored health insurance. Now, when you look at this then in terms of the rate of growth in health insurance premiums, and go back to using 1999 as a base in this graph, bringing it forward to 2010, what we see is that health insurance premiums have increased roughly 4 times faster than prices in general, increased about 4 times faster than wages have grown over the past decade. In other words, health insurance premiums in terms of affordability have grown 4 times faster than our ability to afford them, or the resources we have to afford them. Now, when you put this in dollars, the first 2 bars here show, just in summary fashion, that previous slide in terms of the average premium 10 years ago, about $6,400. The average premium for family policy now, over $13,000. And left unchecked, just the the forecast conservatively in terms of what would happen going forward. This has nothing to do with health reform, even though health reform gets the credit or the blame for much of this trend, which is ongoing anyway. But just looking forward now, what we see is that growing from $6,400 to $13,000, and in 10 years by 2020, the forecast, again, before health reform, approaching $24,000. Now, in terms of affordability, as a share of average income, median family income in this country, the average family premium 10 years ago was 12% of a median family income. This year, 2010, it's up to 19%. So health costs continue to grab a greater share. And at the rate things are going in 2020, again, without any effect of health reform, health insurance premiums would be about 1/4 of a median family income. Now, you don't have to be an economist to understand the concept that if prices are going up, people tend to buy less of it, and that's exactly what's been happening with health insurance. Over the last decade, the likelihood that you as an employee would have employer-sponsored health insurance has dropped from 65% to 59%. This slow erosion of employer-sponsored health insurance is a long-standing trend as health insurance premiums have gone up, and it's just continues as health insurance premiums continue to grow. Now, the increase in premiums actually understates the impact, because year after year, and 2010 is no exception, there's this phenomenon called a benefit buy-down, which is to say, even though the premium goes up a certain amount, it buys you less. Benefits are restricted, coinsurance deductibles go up, and so, or the share of premiums paid by employees goes up. So even though we see this increase in premiums, the employees themselves are not getting the same product that they did 10 years ago. Another effect of the increasing cost of health insurance is that we have more people who are uninsured. And again, you go back 10 years, 38 million people in this country, our fellow Americans, had no health insurance. Now it's 50 million this year. And at the rate things are going, conservatively, 57 million people would be uninsured. That's the CMS estimate. Others have estimated 60 or 61 million uninsured by 2020. Again, without reform. I'm sorry? Oh, sorry. I'm sorry. Oh, well, here we go. I'm sorry. I have to operate 2 clickers here. And, you know, I'm not so good at multitasking sometimes. So one of the other consequences, as there's been pressure on employer-sponsored health insurance and the continued erosion and more people uninsured, is that the number of people on Medicaid continues to grow. And I'm sure you've seen this in your state because it's a universal phenomenon across states now, that Medicaid has been growing and growing very, very rapidly. In the first 2 years after the current economic downturn began, about 6 million people came on to Medicaid nationally. These numbers are the most recent ones that we have through December last year, so they're 12 months old now. But we know from other surveys that we do that Medicaid continues to grow, and there are well over 50 million people on Medicaid now by the best estimates. So it's roughly 8 million people have come on to Medicaid since this recession began. Now, when you graph this now, what you see, and this shows the rate of growth in Medicaid enrollment and the rate of growth in Medicaid spending. And so, and it goes back to the late 1990s. So we see this trend through 2 economic downturns, a mild economic recovery in about 5 years ago, 5-6 years ago, and then the current economic downturn. So what this really shows is that Medicaid's been doing exactly what it was designed to do from the very beginning when it was established by Congress, which is to say it's a means-tested program. When the economy goes down, Medicaid goes up. When the economy gets better, Medicaid goes down. So we have seen that phenomenon. Again, you can see that The primary driver of Medicaid spending is the number of people on the program. Again, you can see the very close correlation between Medicaid spending and the number of people on the program from this graph. What we do see is that last year Medicaid grew by around 8.8%, roughly 9% in overall spending on average in your state, and enrollment grew by 0.5%. When you all adopted budgets for the current fiscal year, the average increase appropriated was 7.4%, based on an assumption that enrollment would grow by 6.1%. So you also know, if your state is like occurred year after year in Michigan, when I was a Medicaid director, that initial appropriation does not always stand, and that it, in many states, it's quite common to come back once you get into the year and you see where things are, to make supplement appropriations, to make adjustments based on what actually is occurring. And in recent years, that's always required additional funding because the program's been growing faster than the original appropriation. That could happen again this year. Now, when you look at Medicaid spending, and I'm going to start talking about now about how hard it is to cut the program or to achieve some savings, slow the rate of growth. When you look at what Medicaid is now, kind of under the radar screen, Medicaid has become the largest health care program in America. And you're running it. It's a state-based program. You make all of the important decisions about the program within the construct of federal rules and financing. But what Medicaid has become this year is $412 billion. I call it a financial glue that kind of holds together the health care safety net. When you look at how Medicaid spends its money, it's about 1/6 of hospital care, a little less of professional services, a high proportion of the overall spending in the country for nursing home care. It's about 8% of prescription drugs. So that's kind of where the Medicaid money goes, but it is 1/6 of all health care spending in this country. By itself, it's 2.4% of the GDP. So it's a very, very significant program in terms of spending. And at some point in time during the year, about 71 million people in this country will have Medicaid as their health care coverage. At any point in time, about 58 million. Now, keep in mind, we're a country now of just over 300 million people. So you can see the share of the population in your state that has Medicaid as its health coverage. Now, Medicaid is many things. We often think of Medicaid as the health insurance portion of it, but it's a lot more than health insurance. It is one of the key roles of Medicaid, and it comes as a surprise to a lot of people to find that 40% of Medicaid spending is for people who are also on Medicare. And we think of people who are on Medicare as having another coverage. So what's the role of Medicaid? Well, Medicaid pays the premiums, coinsurance, deductibles, and for those services that are not covered by Medicare, especially in long-term care. And so, again, when you think about where can you cut the program, you have to think about 40% of the money actually goes to seniors and persons with disabilities who are also on Medicare. Medicaid has a key role in long-term care. We'll talk about that more in a moment. Medicaid supports the safety net in many ways, most significantly through disproportionate share payments to hospitals to help pay for persons that have no coverage at all. And then any place in your budget where there's health care for low-income people, whether it's public health or mental health or education, you'll find Medicaid helping to support the financing of that care. When you look at Medicaid in your overall budget, what you see is that Medicaid is roughly 21%. These numbers are going to be updated next week when the NASBO comes out with its new expenditure report. But it's going to be around 21, 22% of your budget in the new numbers in terms of overall spending, roughly 1/6 of your overall general fund budget. But when you look at the funds that come in to help support overall spending, Medicaid is a huge factor. About 44% of all the federal funds that come to states and this doesn't account for the ARA funds, the enhanced FMAP, but about 44% of all federal funds that come to states comes through Medicaid. Now, slowing Medicaid cost growth is a challenge for many reasons. One of the reasons is that the program actually, notwithstanding some conventional wisdom, is very well administered, and you get tremendous value from the dollars already. Look at this. Medicaid patients are sicker than even other low-income adults with private health insurance. Studies have shown they're about twice as likely to be in fair or poor physical or mental health and more likely to have chronic conditions. And yet, Medicaid per capita costs are lower, about a quarter less for adults and about a third less for children. And Medicaid cost growth has been slower than that which has occurred in the overall health insurance sector. Now, there are other reasons why Medicaid is hard to cut. One is that one of the options is cutting provider payments, but payments are already low in many states. Benefit reductions, as you may have found in your own efforts, sometimes net little savings. A lot of folks cut dental services for adults, for example. That's been the most common cut that states have made in recent years. But yet people may then go to the emergency room when their dental condition becomes so severe. And so you pay for it in a different way when the situation gets worse. You reduce, we used to cut chiropractic benefits a lot, and then people went to osteopaths instead. So, there are many, you cut one thing and the bubble pops out someplace else. When you look at the options now, we've been in this economic funk for so long, almost the entire past decade, that if there were any easy cuts, somebody's already found them and taken them. So when you look in the next year, it's even tougher now. Some options are limited by federal law, for example, on eligibility restrictions under the current situation. And then when you look at the impact of the cuts have real impacts on beneficiaries, providers, and on the economy as a whole. Now keep in mind, Medicaid only covers services which are medically necessary. So when you cut something, or you cut an individual, what you're really doing is restricting access to services that are actually medically needed. And then we find the situation that when you make a cut, who does it affect? And Medicaid spending is concentrated among persons with disabilities and with high medical needs. And when you look at this, you see that, you can look at this in several different ways, but when you look at this, you see that persons who are elderly on Medicare and with disabilities account for 2/3 of all Medicaid spending. We think of people on Medicaid oftentimes as the families and children, but when you make cuts, it tends to affect the elderly and the disabled because that's where the money is. In fact, if you really narrow it down, 4% of all Medicaid beneficiaries account for about half of all Medicaid spending. 5% account for 57%. So, and Medicaid is not different from Blue Cross or any other insurer in this regard. This is just the distribution of healthcare spending, typically. Now, with all the fiscal pressure, states have taken a number of actions to slow the growth of their Medicaid spending. You have to, given how difficult your fiscal situations have been and how large your shortfalls have been over the last couple of years. When you look at what states have done, you look here below the line, you see that states have cut provider payments, they have restricted benefits, they have taken actions in long-term care. Eligibility has been, thank you. Please remind me here. I'm sorry.
It's okay.
There's a 4%, 48%. I'm sorry. So if I'm not in sync or it doesn't seem like, raise your hand or something so that I can know that. But here you see all the actions that, when you categorize them by payment rates, cutting payment rates have been the most common action that states have taken, as well as cutting benefits. The 20 states cutting benefits last year was the highest number that we have observed in the 10 years that we've been doing these annual surveys. So that was something that states did do, which I think shows the depth of the situation that we're in. But there's something else to notice here, and that is that states have been very strategic. That is to say, you'll notice all the states that cut payments But look at all the states. An equal number of states had some provider that got an increase at the same time. So while there may have been maybe an across-the-board reduction, with an exception for, say, for example, dentists, because you had a dental access issue, or prenatal care, because you want to make sure you preserve access for women who are pregnant to that service. That kind of thing, very strategic cutting. The states have become more focused on how they do that. When you look at this, you can see the trend over the last 4 years, looking on the left for any provider that had a rate cut or a rate increase. And then what we see is that last year in particular, the cuts tended to be focused on the institutional providers, that is to say hospitals or nursing homes where rates were either frozen or cut. But when you notice the physicians, last year 20 states had cuts to physician rates. That, again, is a very difficult thing to do and is an indicator of how difficult the situation was. Notice also for managed care organizations, which typically, because of actuarial soundness, have been kind of immune from cuts, but last year and this year, 9 or 10 states actually restricted those benefits as well. Now just a word about long-term care. Again, this shows a little bit about the difficulty of cutting, because a third of Medicaid spending goes to long-term care in one way or another. About a third of that amount, a little more, goes for community-based services and the rest for nursing homes. So when you look at what states have done here, the trend has been, the policy direction has been to try to find ways to encourage care in the community, encourage care in the home wherever possible, because it's less expensive and patients, individuals, beneficiaries tend to prefer care in the home and community compared to in the institution. And so there's been a trend toward expanding what are known as slots in the home and community-based waiver programs, as well as expanding benefits in the home and community, that kind of thing. But because of the fiscal constraints, fewer states were able to do that over the last couple of years. But the long-term effect of this has been that states have continuously moved toward a higher proportion of their services being provided in the home and community. And you can see this clear trend. All of the growth in spending in long-term care pretty much has been in the home and community. And the level of spending in the institutions has been pretty much level. Now, we really need to pay attention to this because we have this age wave, which many of us are part of. But when you look over the next few years, you can see in that box that the share of our population, which is over age 65 or over age 85, is going to continuously increase over the next couple decades, and we have to be prepared for that. And the age is a disability is closely associated with age. So as the population ages, we can expect to see more people on Medicaid who are disabled, and those disabilities carry a price tag in terms of Medicaid spending. Now, one of the clear strategies for Medicaid is to try to expand managed care, put some organization and structure around the delivery system. And states have been doing this, adding new populations, especially the elderly and disabled, into managed care, going to rural areas, going from voluntary to mandatory. States are using their managed care as a platform for quality improvement, using the new data available, new measures through what are known as HEDIS and CAPS, which are measures of utilization and quality and patient satisfaction and that kind of thing, and developing strategies for chronic care management, that sort of thing. We're going to see a lot of activity in Medicaid in the health information technology area, especially encouraging the use of electronic health records. Medicaid has a huge opportunity here to encourage that. Physicians, for example, over the next 5 years can earn up to $63,000 in incentives through Medicaid for the adoption of electronic health records. Now, just the general trend in Medicaid's enrollment in managed care, you can see the trend clearly is upward. About 70% of Medicaid beneficiaries now are in some form of managed care, but there's still room for improvement there. And I show that graph so that you can see how Medicaid has been doing something which is clearly in contrast with what's happening in the commercial sector. You see on this, on the top part, on the green part of this graph, that use of managed care in the commercial side, this is all for employer-sponsored individuals here. So when you see that on the commercial side, the use of managed care peaked about 10 years ago and has been dropping, and this year in 2010 dropped down to 19% from its peak of 30%. So all of the growth in managed care nationally has been occurring in Medicaid, not on the commercial side. Now, this just shows that states have been using managed care for a lot of reasons, a lot of ways to encourage quality, using the quality measures that I mentioned, publicly reporting, putting this in a report card format, putting the results of the quality metrics on the web, requiring accreditation of their health plans, developing disease management programs or other strategies to focus on that top 4% where half of the spending goes, to try to make sure that those individuals are getting the right care at the right time. Again, putting some organization and structure around it. Now, we could spend a whole session just on what states are doing with quality. And I just listed some here without going into great detail, but states have really developed a focus on getting more value for the tax dollars that are going through Medicaid. If we're going to be spending this money, let's make sure that we're getting the best possible quality in doing that. And there's some very innovative strategies in terms of bonuses for high performance, penalties for poor performance, adopting policies so that things that shouldn't happen are not even reimbursable in their program, doing all kinds of things along that line. Now, I just want to spend a moment reflecting on the overall challenge in quality. When you look at all this money that we're spending on health care, are we getting the kind of performance that we'd really like to have? And what we see is that even though we're spending more than other countries, our metrics on quality and outcomes are not better than other countries. In fact, in some cases, quite the opposite. Looking at one of the key kind of bellwether measures, something called mortality amenable to health care. Deaths that could have been prevented if people received the right care at the right time. And what we see here is that when you look at mortality amenable to health care, and the most recent data here show that the United States is that red bar on the far right, which is to say there are no other countries reporting this statistic that have mortality amenable to health care, which is as high as it is in the United States. And in fact, if we were to get to the median on this, we'd have to improve by 25 to 30%. So I love to quote, am I running out of time?
I'm just going to stand up and give you that hint.
All right, that was a good hint. I'm going to go really quick. Can I have 3 or 4 more minutes?
Sure.
Okay, and I'll go. Okay. Jack Lewin, some of you may know, the president of the American College of Cardiology, a physician, former health officer in the state of Hawaii. He says, we have the best healthcare system in the world. We have the best healthcare system in the world. We have the best healthcare system in the world, and it's time to fix it. And this is what he means when he says that, because there are outcomes. We do have the best healthcare in the world, but it's too expensive. And when you look at, this is the graph that the President's Commission on Deficit Reduction looks at. This is what they mean, because when you look at all the things in the federal budget, unfortunately this is true also for your budget in the state level, when you look at everything in the federal budget, you see that everything is level, including Social Security, a little bump there for the baby boomers, but all of the increase, thank you, all of the increase is for Medicaid and Medicare. And so when the Deficit Reduction Commission looks at what has to be done, it's almost impossible not to include some provisions that are designed to slow the rate of growth in spending. So what do we need now? Well, we have an administration. I have 7 more slides. I'm going to go. Now, which is supportive of this. I'm going to go really quick. I'm going to skip over this. You're going to have to go on the web.
You're going to have to click the other.
Yes. Okay. So what we, I'm going to catch up with that one now. So what we have now are the opportunity to really do some things. We've tried the easy things. We've cut payments. We've cut benefits. We've tried to do those things. And what people have come to say is, if we're really going to have an effect on cost containment, on the rate of growth in spending, on what all of this costs, we have to find some way to put some organization and structure around the healthcare system. We have to have integrated, coordinated care, something that so that we have communication in the system, so that it all works better for the patient as well as for the system in terms of its cost. Now, states are doing a lot of things now in terms of health information technology, doing a lot of things now in terms of patient-centered medical homes. One of the big opportunities is with dual eligibles, people on Medicare and Medicaid, where 40% of Medicaid goes. For the first time, we have a new office at the federal level that is designed to coordinate that care and is sympathetic to what states have been saying for decades, that we need to find a way to do this, both for the Medicaid side as well as for the Medicare side. We have a new entity called Accountable Care Organizations, which, again, are designed to have organized, integrated care, where the medical community will come together to put care together in a way that is more effective for the patients and saves money both for Medicaid and for Medicare. There are some things that you can do in terms of prevention, some incentives. There are some opportunities in health reform that can be done. You can look at how you can structure your reimbursement systems to encourage the kinds of outcomes that you really would like. Pay for performance, bundled payments, bundled services, group purchasing, and so on. Within health reform, I have 2 more slides. Within health reform, there are some key things that you can look at. There are demonstration opportunities that you will need to pay. Thank you. I'm way ahead of you here. Some demonstration opportunities are going to be coming down. There's a new federal Center on Medicaid and Medicare Innovation that has $10 billion to award. And there are going to be some real opportunities here, both on the Medicare and Medicaid side, that we're going to need to pay attention to. Within Medicaid itself, the federal law provides for some specific Medicaid demonstration opportunities for global payments, bundled payments, accountable care organizations. There are some pilots for community health centers, and, again, to encourage primary and preventive care, higher payment rates in 2013 and 2014. So that's to catch my breath. What we're trying to do here is, well, just in summary, high health care costs have really created tremendous urgency for states to help slow the rate of growth. And states are in a position to lead on this. There are things that you can do that can transform your system, that can really, really make a difference. And you know, when we were doing our survey and interviewing the North Carolina Medicaid director, Craig and Gray, who's doing a terrific job there with their system. And I remember what he said. He said, we in North Carolina are unembarrassed to use Medicaid to raise the standards of care for the entire state. And I think that's the opportunity that you have in your state. Thanks.